Hello, everyone. My name is Jim Douketis, and I'm pleased to welcome you to tonight's Thrombosis Canada virtual roundtable. Alongside the co-chair with me, Dr. Vicky Tagalakis, we're delighted to chat with you and provide a open discussion for a number of topics that you, the audience, have provided. And indeed, typically when there are educational sessions, it's the speaker or speakers that provide the topics, but here the tables are reversed figuratively, literally, in that you, the audience, are providing the questions and the scenarios, and it's for us to engage each of you in this discussion. First of all, the program that was developed today was organized by a steering committee. Next slide. And the steering committee consisted of a multidisciplinary panel of faculty. And tonight's faculty includes myself. My name is Jim Douketis. I'm an internist in Hamilton. Dr. Vicky Tagalakis, an internist from Montreal. Dr. Stephanie Snow, a medical oncologist from Halifax. And Mr. Ryan Kerzner, a hospital-based pharmacist also from Montreal. And of course, we also have an interest and some expertise in thrombosis. Next slide. We will share with you our potential conflicts based on this slide, which shows each of the disclosures for myself, for Vicky, for Ryan, and for Stephanie. Next slide. We also want to disclose that we've received commercial support from Pfizer Canada in the form of an unrestricted educational grant and potential conflicts of interest for each of the speakers vis-a-vis this educational grant. And next slide. We'd like to disclose with you ways that we will be mitigating potential bias. And of course, we welcome your feedback on this issue or on any other issue. And we're going to go, first of all, to provide a poll before we get to the overall objectives to provide a bit of an outline of what our audience is like. So we're going to get a poll put up for you right now. And if you can take a few seconds to respond. And I hope you can see some of the poll results, but very typical of our panel, we also have a very multidisciplinary group in the audience. So once again, thank you for attending this evening. And let's go on to the next slide, which will outline the overall objectives of tonight's session. So the learning objectives, as you can see, are really quite generic in context that we want to really have a round table. And essentially what we want to try to do in the virtual world is pretend we're all sitting around a table where there's one person leading the discussion, and I will lead the first half, and Dr. Tagalakis will lead the second half, and each of us can discuss a myriad of topics in the thrombosis area. So far, we've received from you some general topics that you want us to discuss. We have also received some very specific cases that you want us to discuss. And by all means, we encourage you to share through the use of the Q&A function, that's just at the bottom of your screen, any questions you may have about the discussion points or any additional questions that may have come up, or if there's a case that you would like to discuss briefly that you've had a challenge with. So it's really meant to turn the tables around in the sense that this is not a didactic session. In fact, it's quite the opposite. It's an interactive session. And let's try to imagine ourselves in a very large round table in a room, not socially distanced, but being able to communicate with each other. And that's the whole purpose of tonight's discussion over the next hour or so. So maybe I can get us started. And before I do that, though, I'd like to ask each of our panelists tonight just to provide a short word or two about themselves, if you don't mind, and just introduce yourselves, if you can do that briefly. And Stephanie, we can start with you.
Thanks, Jim. My name is Stephanie Snow. I'm a medical oncologist. I work here at Dalhousie in Halifax, and I treat a lot of cancers for which there's a fairly high incidence of cancer-related thrombosis. I treat lung cancer, GI cancers, and head and neck cancer. So I'm thrilled to be here. I'm certainly not the expert on clots, but I'm very happy to learn and can definitely give the perspective as somebody with a lot of patients with whom I co-manage and share thrombosis patients.
Thank you, Stephanie. Wonderful to have you. And Ryan, a little bit just about yourself and your practice.
Sure. Good evening, everybody. So I've been a pharmacist at the Jewish General in Montreal for the last 13 years now. Time really flies. So I primarily did internal medicine for a long time. I still am an antimicrobial stewardship pharmacist as well, but always with an interest in thrombosis. And I officially joined the thrombosis team at the Jewish 2 years ago. And I was one of the co-developers with my team of we developed an anti-thrombotic stewardship program where we go around assessing all the patients who are hospitalized on anticoagulants and making sure they're optimized and appropriate and looking at drug interactions and all that kind of thing. So I've been involved with that for a couple of years now.
Wonderful. And Vicky, just a quick word about your background.
Yeah. Hi, hello everyone. My name is Vicky Tagalakis. I'm a general internal medicine specialist at the Jewish General Hospital in Montreal, working with Ryan. And I do have a focus in thrombosis medicine, both clinically and research. And it's really very happy to be here tonight to actually have an open and discussion about some of these sort of difficult situations that come up, or often answers are not that obvious, or there are no answers, but at least we can kind of discuss them and learn from each other. So looking forward to tonight's discussion.
And from my end, I'm also a general internist. I practice at St. Joseph's Healthcare in Hamilton, and also I'm a thrombosis physician. So welcome to our panel, welcome to our audience. Let's now kick us off. We've had a lot of questions sent to us, and perhaps we can go to the scenario slides. And a lot of these questions were actually dealing with areas where, they're kind of special populations. I mean, it seems like the group here has fairly good knowledge about, the standard areas of thrombosis management, but it's kind of more those challenging areas where the guidelines don't often inform best practices, where it's often kind of guidance or expert opinion. So we have some scenarios that were proposed from the audience, and perhaps we can go to that slide next. And so the first scenario, or the questions that were addressed, I'm going to try to break these up into little smaller bite-sized pieces. We're dealing with the first situation, which is increasingly common, and that is the patient who has thrombosis and needs treatment, but is obese, greater than 120, or even sometimes 130 or 40 kilograms. And then we have a separate scenario where there's a patient with chronic kidney disease, And sometimes you get both of those together. So what do you do with one or the other or both of these scenarios together? I think these are all very good questions. Should we use a DOAC? If so, which one, which dose? So lots of questions here, variations and permutations. And I'm going to get us started. And maybe just go to Ryan. Do you have a sort of a general kind of approach to somebody who has obesity or has chronic kidney disease? Are there certain things that we definitely shouldn't do or should do? How do you sort of handle that when you get these referrals or questions from your colleagues?
Yeah, thank you. So that, yeah, this is definitely something we're seeing more and more for sure. To take the two issues separately, and if we're going to start with obesity, I think, well, one thing we can mention is that we do have some sort of guidance that was just published actually last month, I believe. It was from the ISTH, the International Society of Thrombosis and Hemostasis. There was a scientific subcommittee who published some recommendations. After doing a full literature review, they actually noticed that we can actually use DOACs in patients who are greater than 120 kilos or who have BMI greater than 40. And there is more and more published data coming out on this. I know there were subgroup analyses of, and not in the cancer trials, but let's say in Amplify and Einstein, where they looked at the patients who were over 120 kilos, and the rates of VTE and bleeding were quite similar compared to people who were not obese. And then since then, there's been a lot of observational trials, and there's been some meta-analyses that have come out that sort of show that more and more there seems to be some safety data. And a lot of this applies primarily to, I think rivaroxaban is probably the one that has the best data, but apixaban as well. And I haven't really seen much for edoxaban just yet. And so the question for me though, so one thing that sort of comes up, and they mention greater than 120 kilos or a BMI greater than 40, we could, but to me, so a patient who's 121 kilos might not be the same as someone who's 160 kilos, which is something we are starting to see. So I'm still a bit hesitant. So I'm maybe a little more comfortable in patients who are on the lower end of that range. There isn't an upper limit, and maybe there should be, where I would feel a little more secure. As you get to the higher and higher weights, there's less and less data, of course. But that would be, that would be my take, I guess, on the obesity aspect of that.
So I'm hearing that we're having increasingly better comfort levels with treating patients who are over 120 or even over 130 kilos. And we're going to come back to this, but Ryan, I'm going to go back to you again. What's your kind of overall broad take about chronic kidney disease? Are there some, do's and definitely do nots in regards to DOACs? We know warfarin is safe for all levels of kidney disease, but what about the DOACs and chronic kidney disease?
Yeah, the thing we know, of course, and I think we can't forget, is that patients with worse and worse kidneys have, of course, higher bleeding risks as well. And that's something that we have to take into account. When it comes to DOACs, and I think, look, we have data, and we have a lot more data in the AFib population than we do in the VTE population. We know from the product monographs, for instance, we can use apixaban and rivaroxaban down to a creatinine clearance of 15, although that's not based on a lot of good clinical data. But it is something we are, and we even have some dialysis patients on apixaban as well. But those are AFib patients. And when it comes to cancer patients who have a much higher bleeding risk as well, and then you throw in some, reduced renal function, then it gets a little tricky, I find. And above a creatinine clearance of 30, I tend to be very comfortable. But once you get down to, in the 20s or, maybe the teens, maybe the DOACs might lose some advantage because of the risk of accumulation, because of the increased bleeding risk in these patients. And so, yeah.
And I'm just going to go back to the audience. Remember, folks, please, provide some comments or feedback or any questions regarding this. And Stephanie, I'm just going to maybe transition to you a moment. Ryan mentioned about sometimes, chronic renal insufficiency is not uncommon in patients with cancer-associated thrombosis. How do you handle it within the context of, patients, receiving chemotherapy or, other treatments? They may be elderly. What's your kind of perspective on the chronic kidney disease part of anticoagulant management?
Absolutely. So kidney function can be a huge challenge for us because we use a lot of nephrotoxic agents in oncology. And sometimes we're lucky enough that we have alternatives which are equally or almost as effective, but sometimes you're just stuck with one good drug or something that's really controlling a patient's cancer, that's really, maintaining their quality of life from that cancer perspective. But what you're seeing is that creatinine slowly rising up. Now that's a pretty predictable event. Usually it's not like a direct hit to the kidneys that you can sometimes see somebody who ends up with a pre-renal azotemia or something like that. So I like to think ahead. It's really important as well, I've learned this through time, to actually calculate the creatinine clearance, not just to look at the creatinine as you're scanning down your blood work. Most of our patients are elderly. And just kind of the opposite of the first question we've been talking about, obesity, a lot of our patients are quite small. They've had a lot of cancer-related weight loss. So if I'm starting off with somebody who's 78 and, is probably 98, 100 pounds, little lady, even if that creatinine is normal, when I calculate the creatinine clearance, I can really see that it's not as normal as I thought it would be at first glance. So that lets me plan ahead. I'm not always great at figuring out, is this a particular drug that needs to be modified? At what point should I think about getting rid of the DOAC? Since we're really reaching out to our experts can be quite helpful. I am lucky that at our center, I'm right down the hall from hematology. So sometimes it's a matter of, stretching my legs and knocking on a door and saying, listen, what do you guys think of this situation? We also have some great multidisciplinary teams in our clot clinic. There's an advanced practice nurse that if she ever retires, I think the system might just kind of fall to pieces because she's our go-to. So you pick up the phone and you're like, Irene, this is what I'm dealing with. So reaching out for help is very important, especially I find there's more and more new agents and there's more and more data that we're starting to learn. And I know that on the opposite end, like I just spoke about with weight, there's a certain point at which you're supposed to be dosing based on lower weights below certain amounts of kilograms. So it goes both ways. And so almost having those in my head, if I see someone's kind of getting smaller and smaller, say, okay, this is my plan. Would we have to abandon a drug or would we actually just have to modify it? Being prepared and anticipating and asking the question in advance is usually the best strategy, because what we don't want to see happen is catastrophic bleeding or breakthrough clots happening in this very vulnerable population where those kind of events may actually be fatal events.
Yeah, and you certainly don't have as much of a margin for error in your cancer patients as perhaps the non-cancer patients. So those are very good points, Stephanie. Thank you. Let me just put it to each of our panel, and maybe I'll bring in Vicky as well. So here's my question, and I get asked a lot. And people say, Jim, what's your upper limit for weight that you will not prescribe a DOAC? And similarly, they ask, Jim, how low is your creatinine clearance before you definitely have to use a warfarin instead of a DOAC? So I'm going to go around the table here and put everyone on the spot. I feel like the Jeopardy guy. But there, Ryan, let's start with you. What's your cutoff for weight? What's your cutoff for creatinine clearance where, you know what, beyond that, I got to go to warfarin?
Yeah, I wish I had a good answer. And I, would I be comfortable at maybe 130-ish kilos? Sure, possibly after some of the data that I've seen, maybe up to 140, but and we're throwing numbers here. But I think, to be fair also, looking at the overall patient too, and looking at the clot burden, looking at the overall, clotting risk and the bleeding risk and things like that. you know, and the same applies to the underweight as well. But I mean, like, you know, if someone has had extensive clots and keeps getting recurrence, you know, maybe I'm going to stay away from the DOACs in that case. Or if, you know, I mean, there's all these, you know, it's tough. So I think every patient needs to be looked at on a case-by-case basis, but so it's hard to say I have a specific number in mind. With creatinine clearance, honestly, below 30, and especially in, you know, cancer-associated thrombosis, as I said, where the, you know, the clotting risk is so much more elevated than the general population, the bleeding risk is so much more elevated. You know, below a creatinine clearance of 30 in this patient population, I'm a bit more hesitant personally. I'd be a little more, you know, and depending on the agent, so I'm a little more comfortable, for instance, with apixaban, which is the least renally cleared out of the 4 DOACs, you know, compared to the others. So, yeah, so it's, but I would say in general, for an average patient, maybe about 30 mLs per minute as a creatinine clearance.
Okay, so I'm hearing 130 kilos, maybe 30 mLs per minute. Okay, that's fair. Vicky, what's your take on that? What's your kind of comfort level for those parameters?
Yeah, I think obviously to begin with, Ryan's correct in that there's a paucity of actually data in this area when it comes to obesity. There's a lot of studies that are observational, and obviously we know the issues with those studies, but he's right. There are post hoc analyses from the apixaban and the mostly rivaroxaban trials that looked at about 20% of those patient populations were in excess of 120. And as time has gone on, I'm more and more comfortable working above, you know, between 130 and 150 kilos. We're talking about venous thromboembolism here. Sometimes what I've done is, and Ryan's correct, you assess who the patient is. If they have accumulation of other risk factors, if they're obese and, you know, they're paralyzed, or obese and cancer, obviously those are additive risk factors, and I may not venture into a DOAC at that point in time. And another thing I've done, if they're only obese and they're 150 kilos and we're treating a VT, I may start with low molecular weight heparin for the acute phase, you know, 4 weeks to 6 weeks, and then transition over to a DOAC. So I am getting more comfortable, particularly with only sort of looking at rivaroxaban and apixaban in this higher weight for the reasons that were mentioned by Ryan, and based on the recent SSC recommendation that came out. And then for creatinine clearances, again, treating an acute VTE, I'm comfortable going down to, I mean, obviously, once again, it depends on the bleeding risk and who I'm dealing with, whether they're elderly or not, but I don't cringe as much as I used to at the beginning when I'm dealing with creatinine clearances between 25 and 30. So I'm okay, you know, especially with apixaban going down to that. If, you know, I have a patient that is at steady state. And one of the things I'd like to say here is sometimes we're dealing with fluctuating creatinine clearances, like not a steady state. So they've come in with an acute infection or an acute bleed or whatnot. And then obviously you shouldn't be determining their creatinine clearance at that sort of acute stage. And so that's something to keep in mind as well. But those are my sort of cutoffs, Jim. How about yours?
Well, I got to put myself on the spot too. And, you know, I like you, my comfort level has kind of changed over time. I'm increasingly more comfortable treating people who are 130 or even 135. That's probably my kind of comfort level for upper weight. And then on the other side, I think as Stephanie is alluding to, let's not forget, if we have very smaller people, we have to be careful, especially often they're very frail. From the creatinine clearance side, I want to emphasize, I think what the others, yourself and Ryan, has mentioned, that we still don't have a lot of data on patients who are in that 15 to 30 milliliters per minute creatinine clearance range. So we have to exercise caution. In my practice, I might use a low dose regimen like apixaban, 2.5 milligrams or edoxaban. But remember, edoxaban is cleared 50% by the kidney, so we have to be wary of that. And the one question came up is, would we use a DOAC on our dialysis dependent patients? And that's sort of my comfort level hasn't gotten to that point. I think we know of some emerging studies and even trials that are looking at the use of DOACs in dialysis dependent patients. But I think that's where one has to really step back and say, okay, what are we going to do here? We can't really use a DOAC. Warfarin's not a great choice. Do we go to an antiplatelet strategy? Maybe we can come back to that in a separate discussion on hemodialysis. But I want to focus our attention to our audience, and we've gotten a question, and perhaps Stephanie, you can start us off. So one of our audience members is asking about use of low molecular weight heparin among patients who have cancer and venous thrombosis and who are obese or beyond a certain weight, and whether or not in your practice or what you've seen, Stephanie, if there's a kind of threshold of maximum dose that you would administer. And we talked earlier, I think the other panelists mentioned that sometimes we may start off with a low molecular heparin for a few weeks and then transition over to a DOAC. But how do you handle somebody who needs acute anticoagulation? Do you cap their dose, or do you kind of go based on their weight?
That's a great question, and it always seems to be one that comes up as the Friday afternoon consult. I order a lot of CAT scans, so almost on Friday afternoon, guaranteed I get that page. Your patient's in for the routine CT scan, and we happen to find a PE. And while we do have a lot of patients who are quite small, we also have some very large patients. And very recently, I have a young man in his 30s. He's a tall guy, 6'3", 6'4", and his weight is just kind of what we talked about, that threshold of 130 kilograms, and I got called with the PE question. So as I'm prone to do, I did call for help. And I really find that there's two things that happen when we're trying to get these patients going. You want to figure out their best dose. And so we want to make sure that they get the best and safest therapeutic dose, but we also have to make it pragmatic in terms of pre-filled needles and syringes, because a lot of these people do not know how to self-administer. They certainly won't be drawing up a dose like a nurse would be on the floor, a pharmacist preparing that. So we have to make it in such a way that they can go to an outpatient pharmacy and pick it up so that the VON nurses, the home nurses, can actually administer that at home. So we're kind of juggling with, what would the dose be? What do we not want to go over? And then how are we going to actually subdivide that in terms of pre-filled syringes? For that particular patient, he did receive more than 1,800 units, but it wasn't too much more. And I worked it out with our superstar anticoagulation nurse. And just based on what was available in syringes, we elected to end up splitting that into the 2 doses BID for him because it was more convenient. So we also had to deal with the pragmatics of actually getting the doses in. And it's very different if you're dealing with an inpatient as opposed to somebody who's got to go to an outpatient pharmacy and pick that up. But there certainly is a dose at which we would max out. And for instance, my patient certainly did not get a full 200 units per 130 kilograms. My patients are also thrilled when that first month is up and they get to have the conversation about the DOAC, because very few of them are happy to be receiving these needles. And some patients have a needle phobia. They don't want to learn to self-administer. So they're always saying, when can I go on the pill? When can I go on the pill? They all know about these pills. And it's really nice when we can switch them over. But of course, there's some patients in whom it's just not appropriate, who have higher risk of bleeding, for instance, attack GI, primary cancer. So that's one of the other things that we have to factor in as well is what's the reversibility, what's the risk of a major life-threatening bleed if this patient is receiving low molecular weight heparin versus a DOAC.
Great. No, thank you. You covered a lot there, Stephanie, and I'm just going to go over to Ryan now. What's your approach, Ryan? I mean, in your hospital or in your practice, is there a certain, are you going to just stick to the 18,000 unit threshold and not go beyond that, or you're gonna go all the way up to what's your top dose that you've given for somebody with cancer associated thrombosis?
So I have a great scenario, actually. So the quick answer is we definitely don't cap at 18,000. And so we generally, and we usually tend to split the dose after 18,000 or so, sometimes up to 20,000. But if we're going to use the pre-filled syringes, especially to make it easier on outpatients, we'll try to round it off to the nearest syringe and just give that dose split. But I'll never forget, I actually, this was a great, and there's, Vicky, I don't remember if you were involved with this case. I was actually, this was a nice weekend. I was out, it was a gorgeous day in Montreal, walking around, and I get a call from my colleague who, in the emergency, they had a patient who was 300 kilos and who had a DVT, and they're like, what do we do? And I'm like,
Did you say kilos or pounds?
300 kilos.
Okay. Thank you.
And so, so I think what happened was, I think originally they had ordered actually 300 milligrams of enoxaparin, which I was like, not a good idea. And kind of what I said, look, at some point you have to give a somewhat lower dose. Once you get to those weights, there's no rule book really that you can use. And that's where I would, choose something slightly less, like maybe, I don't know, I think I had said something like, maybe give something like 200 milligrams at like Q12 or something, and we'll do anti-TNA levels at that point to monitor, because we would have absolutely no idea what to expect in those weights. I mean, there is data out there, at least with enoxaparin and dalteparin, about using higher doses, and we know there's still not an excess accumulation with higher weights, but I mean, I guess there must be some limits at some point for sure.
Okay, Ryan, I'm going to just ask you to elaborate a little bit about this in this case. Well, you mentioned you were measuring anti-factor 10A levels. When were you doing them, and how were you interpreting those results? And maybe, I'm not sure, maybe Vicky was involved in that case as well, and she can chime in.
Well, what ended up happening, so what ended up happening is they gave the dose, and then it turns out that the patient, I think they didn't suspect it, like originally they were suspecting a clot, and then I think it was ruled out at one point. So I think the patient had just gotten 1 or 2 doses or something like that. But in general, when it comes to anti-10A level, and actually had this patient had a confirmed clot, honestly, I'm not sure how it would have gone. But if we're going to do anti-10A levels, so we do, I mean, we have done it in a few patients. We don't do it very routinely because, we don't have very good data behind monitoring, but we generally do a 4-hour post dose of low molecular weight heparin. And I don't know if we've ever done troughs, and I haven't done it too many times. I don't know if maybe in our audience, maybe people have examples of where they've had success doing it, but Vicky, I don't know if you had anything else.
Yeah, I don't think I was involved with this case, but just in general, I guess it's a very good question vis-a-vis anti-10A usage and monitoring your anticoagulants. So there is anti-10A for monitoring unfractionated heparin and low molecular weight heparin, which can get confused with anti-10A monitoring that's specific, the chromogenic assay testing for the DOACs. And so there is interestingly, there's a resurgence in this anti-10A monitoring for the DOACs, because everybody does always wonder, how can we monitor our DOACs? And that comes up. When it comes to low molecular weight heparin and using anti-10A, it's not a standard thing we do at our institution. We do it in cases where we feel like we want to monitor a recurrence, like we're trying to figure out if the patient failed their anticoagulant, their low molecular weight heparin. Sometimes it may be used during pregnancy, but it's not that often used in monitoring for low molecular weight heparin. When it comes to direct oral anticoagulants, we don't also have standardized protocols to monitor or use anti-10A anti-10A specific DOAC assays. They do exist. We have them in our institution. But given the fact that they're not reliably associated levels with clinical events, it's something that we tend not to reliably use all the time. Now, we may want to use it sometimes when we want to determine if somebody can undergo emergent surgery or urgent surgery, for example, when somebody is actively bleeding and we want to be able to determine usage of an antidote, for example. But more often than not, it's not something that we recommend wide usage for. And you, Jim, were able to show, sometimes we get asked this with elective surgeries, for example, and whether we should be, monitoring or doing antitana testing before their elective surgery, albeit for spinal anesthesia or for the anesthesiologist or for the surgeon. And you were, your PAUSE study was able to document that a protocol of just stopping certain days before surgery, depending on the risk of surgery, was correlated well with these anti-10A levels.
And Vicky and Ryan, thank you for those responses. I think just to try to reconcile it, I think in general what I'm hearing is that we're not going to be doing these tests routinely. The first reason is that unlike with like an INR test or a PTT test, we don't have a well-established therapeutic range. We sort of toss around a range of 0.5 to 1.0 for twice a day low molecular weight heparin, or 0.5 to 1.5 units per ml for once a day, as corresponding to where you want that peak anticoagulant effect. But the overall message is that we want to only do this in specialized situations. And the patient that Ryan described, weighing 300 kilos, I think my approach would be to do a peak level, because I'm kind of worried maybe I'm not giving enough of the low molecular weight, the heparin, and I'm underdosing the patient. So we want that peak level to be at a certain threshold. On the other hand, if it was a patient that Stephanie described with renal insufficiency and they're very low body weight, I'd be worried about giving too much, and that's when I would probably do a trough anti-10A level and to see if there's any evidence of accumulation. So those are the general situations where we want to consider them. The other thing I want to bring back is what Stephanie's point about, a lot of these scenarios involve multiple disciplines, and we routinely, in my practice, and I think everyone's practice, we're consulting our nephrologists or our hematologists or our pharmacists often that sort of provide a consensus approach. And I see there's a comment also from an audience member, and in regard to the patient that you just described, Ryan, mentioning that in an ICU patient who was obese and received low molecular heparin, the 4-hour post dose or the peak level ended up being above sort of that threshold that I kind of mentioned of 1.0. And it's mentioned that the dose was subsequently decreased afterwards. So I think with the obese population, the other thing we don't know very much is what is the volume of distribution of a drug, and that may not correlate linearly, with their body weight. So there's some uncertainty there. Okay.
If I can add.
Yeah, please.
Sorry. So I was going to add, especially in the ICU population, and we know that the pharmacokinetics of low molecular weight heparins are they're a bit less predictable. And we know, for instance, they might actually require higher doses than the regular population. And then the other point also, and which I've always wondered about, and I'm not sure, but in obese patients, I don't know if you have a very obese patient, is do you actually obtain a peak at 4 hours? So are you actually measuring an appropriate peak? Is there like an extra delay because of the extra tissue? And I've seen that being discussed, and I don't know for sure.
Yeah, you're right. That is often discussed in the subcutaneous depot of the low molecular weight heparin, and how that can change according to when there are extreme weights. So it's hard to know. And that's why I've seen some people say 4 to 6 hours post to do a peak. But yeah, it needs, and I guess just Jim, was this adequate? The question, meaning I guess that it was done 3 days after the initiation.
Yeah, what do you think? What do you think about this? Is a very good question from Philippe. What do you think? How would you have handled this, Vicky?
It's very. I mean, I guess it depends. Usually, you don't have to wait 3 days later to do the antitana because the action. I guess it's based on the half-life, perhaps, of obtaining an that we usually see with other traditional oral medications. But here, I think it could have easily been done earlier than 3 days, and that's been my experience. Whether it was it's hard to say.
The only thing I could add is this is an ICU patient, so they're already intrinsically at higher risk for bleeding, and if there was a peak level done, whether it was 2 days or 3 days after the initiation of low molecular heparin, I think it would have been reasonable to decrease the dose, but with the only caveat that I probably would repeat the level and maybe not decrease the dose too much, not more than 15 or 20% empirically. This is completely empiric, and just being aware that there's going to be some intra and even inter-patient variability here. So yeah. I think it was reasonable to do that, but with those caveats. I'm going to be passing the baton off soon to Vicky, but before I do that, I just want to go back to Stephanie, because we've been talking about, not giving enough anticoagulants because we're worried that we're going to increase the risk for thrombosis. But we're also want to look at the flip side of things. And Stephanie, in your area of cancer, you're dealing with a lot of patients who are at increased risk for bleeding, and we're worried about causing bleeding. Can you maybe just, and this question came up from one of the pre-panel discussion points. Can you describe some scenarios where you'd really be worried about giving anticoagulants, where you want us as clinicians, as non-oncologists, to have a heightened sense of awareness of, here in these situations, be careful about anticoagulating patients because, whether it's the tumor type or the tumor location or the chemo, what are scenarios that cause you to be a bit nervous about bleeding in cancer patients who require full anticoagulation?
Absolutely, Jim. That's something we deal with almost on a daily basis, because it seems like many of the cancers with a higher risk for bleeding are also those that actually carry a higher risk for cancer-related thrombosis. So in my particular practice, it's generally my gastric cancer patients that I really worry about. A lot of those patients will bleed, but really any intact tumor along the GI tract does stand at risk for bleeding. And the same very much applies as well for a lot of the genitourinary cancers, bladder cancers in specific. They can lose a lot of blood quite quickly. And of course, gastric cancer has been noted to be one of those with a specifically high risk, where we even sometimes talk about should they be prophylaxed against VTE before they even get one. There are other tumors that like to spread to the brain. And so we have primary brain tumors, again, a high risk for VTE related to cancer, but some of those in particular have a tendency to bleed. For instance, thyroid cancer, when it spreads to the brain, melanoma, when it spreads to the brain, they're very often characterized by bleeding from those metastases. So all of these sites have a risk for bleeding, and they're not always the easiest sites to get at to do an intervention. If you've got intracranial bleeding, or if someone's having a massive bleed along their digestive system, they can't necessarily get to it that quickly with endoscopy to be able to, cauterize or to do those kind of direct interventions. So those are the patients where we're generally more cautious. And when we're in doubt, we generally would try to err away from the DOACs. But again, we have those conversations. But by the same token, sometimes we're even thinking about, is this somebody who should be prophylaxed to keep them away from full dose anticoagulation in the first place?
Okay, well, thank you, Stephanie. So obviously certain tumor types, especially primary brain cancers, gastrointestinal and genitourinary cancers, we have to exercise caution, and maybe here, the needle goes towards a kind of a lower dose regimen, or even a low molecular heparin with a shorter half-life. All right, well, I'm going to pass now the baton off to my co-chair, Dr. Vicky Tagalakis. There's going to be a number of other questions, again, special population related, and Vicky, over to you.
Sure, thank you, Jim. So maybe we'll go to the next scenario, David. Great, thank you very much. So here we have an interesting question having to do with a patient who suffers from seizures and who develops atrial fibrillation or suffers a deep vein thrombosis. And rightfully so, you wonder about any significant interaction between the seizure medication and the DOAC. And is there a preferred DOAC to be used? Is there a universal DOAC that you don't necessarily need to worry about drug-drug interactions? And so maybe I'll start off with Ryan, and certainly we can also discuss along the same theme, drug-drug interactions when it comes to a lot of our chemotherapeutics. And maybe Stephanie can help out with that later. But Ryan, what do you think about this scenario?
So this is literally a weekly question for me when I'm on thrombosis pharmacy service. So this one, to answer the second question, there is no preferred DOAC. So all the DOACs. So just to recap quickly, so all of the DOACs are PGP substrates, and PGP, for those who aren't aware, is it's an ATP dependent efflux pump that's found sort of all over the body, but really. For us, it helps sort of pump the DOACs back into the intestinal lumen to try and eliminate them. And so any drug that might inhibit that PGP will increase the effect of the drug, or if you induce the effect of PGP, you lower the effect of the drug. And then you have, so all of the 4 DOACs are equally all PGP substrates. And then you have apixaban and rivaroxaban, who are also cytochrome 3A4 substrates. And so the same thing applies with inhibition or induction. Whereas edoxaban and dabigatran themselves are just PGP, or like edoxaban is very minutely 3A4, but not clinically significant. And so any drug, and the anti-seizure meds are probably one of the big classes that interact. And so you have the classic, so it's phenytoin, carbamazepine, phenobarbital, which are complete contraindications for all of the DOACs because they are all very potent inducers. And so really you can decrease your levels by even by 100% in some cases. So a full a decrease by half, I should say. And so quite significantly. And so I would never, ever take the chance. That being said, and then you have the one thing, and I could say, and I think it's an important point to mention, I've given a few talks on drug interactions with the DOACs already. And the one thing I've learned, and I've learned throughout my practice, is that drug interactions are so much more complicated than I ever thought. And so when you're looking, and I'll give you the perfect example, and if we're talking about anti-seizure meds, you talk about levetiracetam or Keppra. And that one, if you look, will actually be listed in some tables as a inducer of PGP, and I believe the cytochromes as well, I forgot. When I first saw that, I was freaking out because we always say that that's like kind of our go-to anti-seizure if we can. There's also lamotrigine. There's a few others, of course, that don't interact. And when I saw that, I was like, whoa, like, what have I been saying for all these years? And what it turns out is that there's a lot of drugs that in vitro might show some type of induction or inhibition of PGP or the cytochromes. But when we look in vivo, absolutely nothing is found. And some studies are done in animals versus humans, and we'll see sort of certain drug interactions that have been shown in animal studies, but have never been realized in human studies. And so, so just to show you really how complex, you have to be very careful when you're looking at the source of the information and to really look at the details of where that's coming from. And if you want the best example is dexamethasone, and this is one that comes up all the time. And you know, how many cancer patients are on dexamethasone for, I'll tell you, for nausea, for brain mets, and for all the other indications we use dex for. And dex itself is listed as a very potent inducer of PGP and possibly a moderate to strong inducer of 3A4. And so there was actually finally, and just even it was last month in Thrombosis research, in the journal that just came out, and there was a group who actually, and they took advantage of COVID where everyone's getting dexamethasone for the treatment, and they looked at all the patients who were on DOACs, and they actually found no difference whatsoever. So they measured trough levels peak and trough levels for what it's worth. We don't have very good data, but it sort of correlated to what we found in the studies of all the different DOACs. And so basically showing, and this was the first time that I actually saw any data that sort of made me feel somewhat better about using dexamethasone. Now, it's not perfect and it has its limitations for sure, but it really is a complex kind of issue for sure.
Yeah, no, definitely. I think many of us have cases that come to mind. I know, Jim, I think you had a case you wanted to discuss where there was a significant issue regarding drug-drug interaction with a patient.
Yes, a few months ago in the internal medicine clinic, I diagnosed a 60-year-old woman with trigeminal neuralgia, which, as you know, can be very painful and chronic. And she was treated in consultation with a neurologist on lamotrigine and carbamazepine. And then a few months later, guess what? She developed unprovoked deep vein thrombosis. So, of course, as Ryan was saying, these are drugs with potential interactions with DOAC. So she was initially treated with low molecular heparin and then warfarin, but couldn't get to the INR testing done reliably, poor venous access. So then one of the other docs switched her to apixaban and was going to do levels, like in this case, peak levels, to make sure she's getting enough of the drug because it's an inducer, so it may lower the anticoagulant effect. So, we weren't able to get reliable testing done that way, so I kind of bit the bullet, and you can criticize me, but I switched her to edoxaban once a day, thinking that, there may be a little bit of interaction, but I've heard that it's through a number of our pharmacy colleagues that it may not be as significant as with the other DOAC. So what do you think? Should I be doing what I'm doing, Ryan or Vicky, or switch strategy?
Yeah, so I've seen, I was always a bit hesitant with carbamazepine, and with carbamazepine, there's a ton of published case reports, and that's where a lot of the data comes from. And I remember there was actually a similar case. There was this case, I believe it was in England, a patient who was on warfarin, was tired of being on warfarin, and he was on carbamazepine and didn't want injections. And so they put him on apixaban. The patient comes in a month later with TIAs. He was for AFib, and we came in with TIAs. They actually measured apixaban levels, and they were like almost non-existent. And then they switched him to edoxaban. And about a month later, brought him back in, did trough levels and peak levels of edoxaban, and the levels were actually normal, quote unquote. And so I've seen a few of those published right now with edoxaban and carbamazepine. Look, sometimes sometimes we bite the bullet and see, and it's, look, sometimes I definitely believe in getting, if getting the patient involved in that discussion and having them aware of what the risks and benefits are of potentially, of this potential interaction. But yeah, look, I've seen a few little case reports with edoxaban, maybe with carbamazepine. I mean, edoxaban has the advantage of being just PGP, and it's not, and maybe that's where some of the advantage comes, right, for sure. But yeah.
Hard to say. I'll just end. I do see an audience member asking, how about the Trixaban? I don't know much about it, and would it solve the PK drug interaction if it were available in Canada? So yeah, it's not available in Canada, but I don't believe it would solve the PK interaction because it too has dependence on the same mechanisms. I'm not super aware, but I would think that it would be an issue as well for Vitrixaban as well. That's licensed in the United States for extended prophylaxis in medical patients. Jim has a question.
Well, actually, I think that drug has been taken off the market, if I'm not mistaken. So I don't know if it's used anymore in any clinical scenario, but it was one of the newer DOACs with, I think, a fairly long half-life. But certainly, it's not. I don't think it'll see clinical use in Canada.
Yeah, well, I wasn't aware, but I think anyway, in the United States, it had been licensed for extended prophylaxis a few years ago. Okay, so I think, Stephanie, maybe I wanted to ask what you thought about the drug-drug interactions and how you deal with it in oncology with your cancer patients who have concomitant DBT or PE and need to be treated.
Absolutely. So we're very lucky that we're in an era now in medical oncology. We have more and more targeted therapies, as opposed to those more general cytotoxics like chemotherapy. The problem is a lot of these come in oral forms, and the tyrosine kinase inhibitors, generally at the end of the word NIB, is generally metabolized to the liver. So a lot of potential drug interactions. And when we just had 2 or 3, we would kind of print off a list. These are the inducers. These are the opposite effect. And you have to be careful in cancer because if you get too much of an intended dose, a lot of these targeted therapies can have quite significant adverse effects. But by the same token, the role they're playing in controlling a cancer is also critically important. So you need to make sure your patient's getting a therapeutic dose. But it seems like every day now there's a new report of a brand new tyrosine kinase inhibitor for this, that, or the other. So this is really where our oncology pharmacists are critical. Sometimes they have access to databases that I don't, where they can run for interactions. And they're really good at going right to the source, saying, okay, how is this drug metabolized? But as Ryan said, sometimes some data is based on in vivo, some in vitro. One database will say absolutely not. One will say, well, kind of think about it. And so you have to be very careful when you're making these choices. So sometimes it's better to make a prophylactic type of choice, saying, listen, I've got a patient here with brain metastases. There's a significant chance they might end up needing to go onto a DOAC or even an anti-seizure medication. So if I'm going to make a wise choice, sometimes it's better to pick something with less potential interactions if I have multiple therapeutics at hand. But it's a very difficult literature to keep on top of. So again, really the key here is multidisciplinary and reaching out to our pharmacists.
Great. And I think the issue with the pharmacist being involved in the care of these types of patients is so crucial. And often it's really a balancing, mitigating benefits versus risks. And like you said, often these are crucial medications. They're TKI inhibitor and need to be really assessed in the context that the patient cannot really be afforded full therapeutic advantage with continuing their medication. I wanted to then move on because we have a couple of more scenarios that I wanted to get through in the next half hour. So if David, you can forward the slide, please, to the next scenario. Hello, David. Great. So here we have, a very important question often faced in dealing with bleeding and critical bleeding in cerebral bleeding. So here we have a patient with a history of venous thromboembolism and antithrombin deficiency and a strong family history of venous thromboembolism. So very prothrombotic individual who presents with a spontaneous intracerebral hemorrhage with an INR of 2.3. Presumably this patient was on warfarin and suffers this intracerebral hemorrhage. And the question we're often faced in these patients is, obviously after the initial management of this intracerebral hemorrhage, is when to resume anticoagulation and ways to optimize or to prevent that recurrence in bleeding. So I think it's sometimes often we may have to face this situation when dealing, for example, Stephanie, you had mentioned earlier, the bleeding risk associated with several types of malignancies that tend to bleed when they metastasize to the brain, such as thyroid, melanoma, for example. What's your sort of perspective on this?
So, I mean, it's really a matter of competing issues for mortality. It's nice when we can also, in terms of the multidisciplinary team, engage our radiation oncologist, because often a treated metastases is going to be much less prone to bleeding. So earlier I mentioned, for instance, gastric tumors. Almost all my patients, when I first meet them, they're anemic, they have iron deficiency in addition to the ongoing bleeding. But a few quick short shots of radiation, 5 doses, can be enough to kind of dry up those tumors, and you can really mitigate that risk for bleeding. So somebody who's having an active bleed is somebody who's different, who has an untreated metastases, which is at risk for bleeding, which is also different from a patient who's had some radiation. And so I think taking all of those things into consideration, in addition to what is their systemic therapy, for instance, we use a lot of VEGF inhibitors. VEGF inhibitors in and of themselves have a risk for both bleeding and clotting, and trying to put it all in the context of what are the patient's goals, what's their life expectancy, and what would be the overall impact of a event, either be it clotting or bleeding. But often if it's specifically the bleeding that we're concerning about, radiation oncology can be really good at kind of what we call drying up that tumor.
Okay, good. I don't know, Jim, how would you address this in this patient? What do you think about using, for example, does the type of intracerebral hemorrhage impact on your decision, whether it's a lobar intracerebral hemorrhage or something a lot more deeper that perhaps doesn't have such a high risk, or a subdural hematoma? Do you use your neurologist and neurosurgeons in that discussion to determine when you resume anticoagulation? Because obviously here, this patient is very prothrombotic, and we know that we need to address that as quickly as possible, but as safely as possible.
You've hit the nail on the head, Vicky. When you're dealing with any kind of major bleeding, whether it's intracranial, gastrointestinal, or genitourinary, I think, and these are all complicated cases, but they're also very patient specific, because you want to try to estimate what is their risk for having another bleed. As Stephanie said, if it's something that's treated, in the case you described with radiation, then that risk for rebleeding decreases. And similarly, if it's a type of bleed that is treatable, like a subdural, then that's very different from a deep intracerebral bleed, or for that matter, a bleed that is a small bleed that's following a stroke syndrome, like a hemorrhagic transformation. So it really is completely predicated on where the bleed is, and more importantly, what the risk for recurrent bleeding is. In this specific case, I think I'd be more concerned about the bleeding part than I would about the thrombosis part, because although antithrombin deficiency overall in the long term is a very prothrombotic condition, in the short term, the risk for recurrent thrombosis is still pretty low. I think it's kind of like around 1 or 2% per year. So I think my concern here would be more on the bleeding side. Having said that, what I see in practice in a lot of these cases of especially GI bleeding is that clinicians are more worried about the bleeding side and forget about the thrombosis side. And we know that there are emerging data that suggests that no, you should actually try to put that person back on anticoagulant therapy, because you reduce the risk for stroke, you reduce the risk for mortality, but do it judiciously and according to the type of bleed and the location of the bleed.
Yeah. I can certainly add, I mean, we're faced with this very often, and not every intracerebral hemorrhage is the same. And certainly some have a much higher risk of rebleed than others. So, in my own practice, I often work closely with the neurologist and or neurosurgeon. And for example, an amyloid type of bleed will likely rebleed. So you want to be able to wait at least a few weeks and before resuming anticoagulation with repeat scanning, versus a small thalamic or basal ganglia type of bleed, where my neurosurgeons and neurologists feel that risk is a lot less than a lobar sort of hemorrhage. And so these are often discussions that have to be done in a multidisciplinary fashion. And more often than not, it will require a minimum of days to a few weeks before resuming, depending on the situation. And Stephanie's right, using other avenues to mitigate that bleeding, such as radiation therapy, is important. Or if the patient had a subarachnoid and that aneurysm was dealt with by neurosurgery, then obviously that risk of rebleed is also less. So these are the things to be considered. I think what we'll do is we'll move on also, because we have a couple of more scenarios, and I'm mindful of the time. We have 20 minutes left. So here we have a 70-year-old male with PGI Staph aureus requiring treatment with rifampin and doxycycline antibiotics long-term, at least 6 months. Oftentimes these patients have perioperative blood clots requiring treatment, but in this case, the indication is AFib. He has hypertension, dyslipidemia, aortic valve sclerosis, mild aortic regurg, and mildly dilated aorta. He's an ex-smoker and not currently smoking, non-obese, no renal dysfunction, history of cancer, but stable pulmonary nodules that are not treated, and his AFib is paroxysmal. And we see here that medications include ramipril, rosuvastatin, tamsulosin, ciloxibib, PRN, and indapamide. And his current blood thinner is enoxaparin, which he was switched to 6 weeks ago from edoxaban when he was put on rifampin. And now the patient is refusing these injections, and the service or this participant says, we are consulted requiring oral alternatives. Is warfarin an option? So maybe Ryan, I'll ask you to tackle this question first.
Yeah. So yeah, for me, with rifampin is first, every time I see it, it's like a nightmare. Pharmacists hate rifampin, I'll tell you.
Terrible
yeah, so this
rifampin.
Horrible. And I work in infectious disease also, so it's like but so look, rifampin is one of the strong inducers we have of PGP and several of the cytochromes. So for me, this one, like warfarin, is the only option. And I think the thing to consider is, keep in mind with rifampin is So at least in this particular patient, the rifampin has already been on board, so you should have a stable amount of induction already present. And so it's just a matter of finding that dose of warfarin, and it, very likely will require a higher dose than usual to get there. But and then of course, once you're stopping rifampin, and just remembering that when you induction, so in agents that do induce PGP or the cytochromes, they can take often a week to even 2 weeks to wear off fully. So it's a matter of then really doing much closer warfarin monitoring. And I know now with the pandemic, it's a bit tough because, it's harder to do some monitoring sometimes, but in this particular patient, I mean, it's not easy doing warfarin with rifampin, but I mean, in this case, it would be the only option that I could see. Like there's no scenario where I would use a DOAC with rifampin. There's no data for increase that I've ever seen for increasing doses of DOACs above the usual recommended doses to deal with the induction. But so that would be my answer. Yeah.
Have there been, with any of the panelists, any experience with virtual following of warfarin management virtually? Stephanie or Jim or Ryan?
General warfarin's a no-no for cancer patients, so
right.
we avoid it like as far as we can.
Well, we've certainly discouraged people from using warfarin, and we've tried to transition a lot of them from warfarin to a DOAC. And it's been driven by the pandemic and to limit sort of interactions with healthcare personnel. But, for virtual management, I mean, in our place, we're doing a lot of that for monitoring of anticoagulation, whether it's a DOAC or warfarin for perioperative management, and also for sort of long-term follow-up of our thrombosis patients. So certainly virtual care will have a greater share of our day-to-day practice going forward, even after the pandemic. But I, for what it's worth, have found it very easy, and patients like it a lot. They don't have to wait for an hour sometime or have to pay $20 of parking.
Right. Yeah. We've also during this period of the pandemic. There were, patients that were followed in our Coumadin clinics, quote unquote. This is what we call our warfarin management clinic, who, 25% to 30% within 6 months, we had transitioned over to a direct oral anticoagulant. And for others, we, obviously explored, point of care and local pharmacy champions to help with overseeing the maintenance of their Coumadin dosing.
But Vicky, just going back to the case, certainly as Ryan described, warfarin is kind of the default option here because of the drug-drug interaction. The only other option I would consider as an alternative, and I'm looking at this patient, 70 years old with hypertension, so his CHAD score is 1, at least I'm missing unless I'm missing something, or his CHAD 65 score is 2. So his baseline risk is not, terribly high. And sometimes what I've used in situations where I can't use an anticoagulant is a combination of aspirin and clopidogrel. And there are data to support that as an effective antithrombotic regimen for stroke prevention. So I don't think it should be frontline by any means, but it just is another option that, could be considered.
Mm-hmm. Yeah, no, for sure. Given that the CHADS is low, as you say. I was going to move on to the next scenario before we do that, maybe there was a question in the chat concerning COVID and anticoagulation, and certainly some folks wanted our thoughts on the use of full anticoagulation with heparins in non-critically ill patients with COVID-19. I know the newest article has suggested benefit. Do any of you follow this practice? I mean, I certainly can, Brian, maybe you can start off, because I know you and I have been involved in our local COVID-19 guidelines in anticoagulation, and perhaps you can comment on this.
Yeah, so we, since the preprints came out, we had actually made our switch over to therapeutic dose anticoagulation for the non-critically ill population. So now any patient who comes in who's admitted on oxygen to our wards gets full dose low molecular weight heparin. And if they're in the ICU, we've still maintained intermediate dose anticoagulation in that population. The only exception is sometimes if we'll have more stable patients who are just on Optiflow, who go to ICU just temporarily, we would maintain that full dose. And if they don't have any other organ involvement or any other, if they're not on pressors and things like that, so they would maintain, but that's in general our protocol. Yeah.
Okay. Stephanie, do you have some idea of what goes on in your institution? Although it's not in the oncology specific realm, you may be aware of how you're dealing with full dose anticoagulation or not in your units.
So in general, all cancer patients will end up prophylaxed when they're in hospital. We'll usually use a low dose of low molecular weight heparin. Often our patients are hospitalized for the reason that they can't keep down pills and fluids. For instance, somebody with intractable nausea and vomiting is not a great candidate if they take their DOAC and it comes right back up. We would not want to see patients with a prolonged hospitalization from complications. So it's kind of the part of the checkbox when we're admitting people to think about anticoagulation as a prophylaxis. And it's more challenging when you have somebody who's established on an oral agent, but they haven't been able to take it. And so it's not always just a matter of being able to keep it down, but sometimes we're wondering if people are absorbing. We can have patients with a lot of promotility from chemotherapy, for instance, a lot of diarrhea. We have gastric patients with dumping syndromes where things are moving through quite quickly. So we often sometimes wonder as well about oral absorption. So just to be safe in the critically ill patient, we would generally, for our inpatients who almost all would have active cancer beyond active therapy, elect towards the smaller dose of the prophylactic low molecular weight heparin.
Right. So that would be, in general, we would do the same in our hospitalized cancer patients who do not have COVID-19 co-infection, definitely. The message here is that thromboprophylaxis at a minimum needs to be provided as per local protocols. An escalation to therapeutic dose, given the recent data that's come out, has been convincingly very positive for therapeutic dose in the non-critically ill patients. I wonder, Jim, what does your institution do in this with these patients?
Well, I'll tell you, I was very strongly in favor of escalating to a therapeutic dose regimen back in January when the evidence came out. And I think now there have been additional trials, some presented in abstract form at ESC and other meetings that converge in terms of their findings that there is that sort of therapeutic sweet spot where a full dose anticoagulation has benefit. And as Ryan alluded to, if somebody is transitioning over to a critical care environment, whether it's for non-invasive or invasive ventilation, then we sort of scale back. And in our case, we go to a prophylactic dose. But I'll tell you, there was a lot of reticence among my colleagues to adopt this approach. And I think it was because, if you think about it, we're giving full doses of an anticoagulant in patients who don't have a clot. You know, we're treating their COVID essentially in microthrombosis. So there was a little that it was hard for some of them to wrap their head around, although I think we need to emphasize that the approach seems safe. And heparin, as we know, have pleiotropic effects, some of which are anti-inflammatory effects. And patients with COVID-19 are benefiting. So I think the balance of evidence, in my view, supports its routine use, unless there are, of course, contraindications. And then in patients who are in an ICU setting, to scale back. And, there are other questions now. What happens when they go home? Do they need to continue anticoagulation? We're not sure about that. And what if they're not sick enough to be in the hospital, but they have COVID? Well, probably we shouldn't prophylax them, but certainly a very, very interesting kind of paradigm shift with anticoagulant use.
Yeah, no, definitely. And it's always there is data still to come, especially moving into, as you mentioned, the outpatient setting, post-discharge, or even patients who are not admitted to hospital and have a COVID infection, and whether or not those patients should receive anticoagulation. But I'd like to actually focus on something that Stephanie said, and I think it's a good sort of prelude to the next scenario, or one of the other topics of discussion having to do with GI absorption of DOACs. Thank you, David. So in fact, I think Stephanie was bringing up this issue about, especially when dealing with cancer patients, and there's this whether to use a low molecular weight heparin or a direct oral anticoagulant. Are there situations where the direct oral anticoagulant is not an option that is a reliable option? And one of these is the GI absorption, and that is something that we often don't think about, but oncologists like Stephanie have to deal with this often with the chemotherapeutics or medications that are given, the nausea that these patients have, or the surgery that they undergo where there is, they've undergone some sort of GI resection, gastric resection or somewhat, and therefore absorption of the DOAC is an issue. So I'm wondering how this comes into play for you, Stephanie, when dealing with these patients.
So I think at the end of the day, we err on the side of being safe. And so if there is a question about absorption, we would generally go with a more reliable, although sometimes less convenient, subcutaneous low molecular weight heparin type of approach. I haven't actually seen us doing things like checking levels, which I guess could be an option for somebody who absolutely was not agreeable to receive any needles. But I think that because when you think about it, clots are the second cause of death in cancer patients. We really have to be careful. Our patients are so vulnerable. And so if there's any questions to whether or not they're actually receiving that therapeutic dose, we always would just err on trying to get as much stuff in via a different route than the actual digestive system.
Right. So I guess the often this audience member wondered about disease states where GI absorption is decreased, and they're not. And I have to agree, they're not easily identifiable. And so your message being always err on the side of safety and efficacy, and making sure that you're treating that patient makes sense. Certainly, Ryan, we sometimes wonder about the DOACs and where along the GI tract they're absorbed. Do you have any sort of information to help guide us vis-a-vis the absorption of these DOACs along the GI tract? And presumably that can help us identify better who we can and cannot treat.
For sure. So yeah, that's definitely an important point. So, and we don't always have great data on the site of absorption of drugs always, but with the DOACs, that's something that has been looked at. And so we know, for instance, that rivaroxaban is the most proximally absorbed. So generally in the stomach and in the proximal small bowel as well, in the duodenum. Whereas edoxaban is more sort of in the small bowel, and apixaban is actually absorbed much more it's actually absorbed throughout the bowel, including even down to the colon. And so and with cancer patients, you have to be very, of course, we want to make sure, obviously, if they're on a highly emetic chemotherapy agent and they can't even take the drug, well, that's going to, of course, 100% impede absorption. But, and you look at other GI toxicities that Stephanie alluded to. So even, patients who are on chemos that, you get severe mucositis or stomatitis or things that will affect your gastric motility, of course. And there's quite a few of those that can actually act on those ends. But the other thing and then if you have patients who have tubes, so patients who let's say for various surgeries, and so if you have for instance, a tube that bypasses the stomach, or where the contents will, let's say, enter the small bowel and will bypass and miss the stomach, well then, for instance, rivaroxaban is probably the one that you're not going to want to use as an example. And keep in mind, rivaroxaban, of course, needs food. If you're going to use the 15 or 20 milligram tablets, you have to be able to have some type of food input. Otherwise, you can decrease your absorption by about up to 30% even. And so those are some of the things to keep, yeah. So I think I hope that helps answer that a little bit. Yeah.
Yeah, no, this is super important. And it led me to think about experiences with bariatric surgery, which is, kind of circling back to our obese patient population. And I don't know if maybe Jim has some experience with that patient population.
We do, Vicky, because our hospital is a bariatric center for surgery. So we have to deal with these patients not infrequently. And I certainly echo Ryan's point that generally the consensus is that we probably want to avoid certain DOACs, especially rivaroxaban, where you need the proximal part of the gut and for absorption, and with dabigatran, where you need that acidic stomach environment for absorption. And we're tending more to go to apixaban, where it's kind of more spread out in terms of its absorption, and edoxaban. This is an area in its infancy. Sometimes we've done DOAC levels, but it's an area that you certainly need to take that into consideration when you're providing anticoagulant options for these patients.
Yeah. I think we're at the end of our session today. And I think we went through almost every scenario that was presented to us. And the last 2 points there had to do with anti-10A monitoring and kidney disease. So I really thank the panel for really tackling these quite important questions that are difficult and challenging to deal with. I hope the audience had the opportunity to ask their questions in the chat box. There are opportunities of more virtual roundtables, 3 more that are going to be coming up in the next couple of months. And so there are opportunities to participate in those if your questions were not answered at this virtual roundtable tonight. We do want to ask one final sort of ask that we have is that there is an evaluation that we really would hope that you could complete, because it does help us in planning for our next virtual sessions. And I think David has posted the link to completing the survey. And with that in mind, I wanted to thank all our panelists. Again, Ryan, Stephanie, and my co-chair, Jim, for this excellent discussion tonight. I also thank David for helping with the logistics tonight. And I wish everyone a good evening, the rest of your evening. And thank you very much for coming out and participating.
Thank you.
Thank you very much, everyone. And don't forget to check out the Thrombosis Canada website. A lot of what we've talked about is there, especially we're going to have a new drug-drug interaction tool available.
Excellent.